Nurses are healthcare professionals who will be with you from womb to tomb. They provide holistic care to individuals of all ages, families, groups and communities, sick or well, in all settings. Nurses, being involved in the broad spectrum of healthcare that caters to individuals, families, and groups, are in the position that makes a difference to direct and improve people's health in different settings. It has been over a year since the COVID-19 first emerged, and this disease has caused a big impact on the health and economy of most countries. Until today, the pandemic has caused a great toll on the physical and mental well-being of nurses and other healthcare workers. ICN reports that the phenomenon is complex and intertwined with various issues, including persistently high workloads, increased patient dependency and mortality, occupational burnout, inadequate personal protective equipment, the fear of spreading the virus to families and relatives, an increase in violence and discrimination against nurses, COVID-19 denial and the propagation of misinformation, and a lack of social and mental health support. They have also projected a global shortfall of more than 10 million nurses by 2030. That does not take into account the continued and growing effects of the pandemic. The Strategic Directions for Nursing and Midwifery 2021 to 2025 comprises 4 policy focus areas to improve the nursing profession: education, jobs, leadership, and service delivery. Each focus area has its strategic direction, articulating a goal for the 5-year period. Enactment of the policy priorities can support advancement along the 4 strategic directions. Each area has between 2 and 4 policy priorities, which, if enacted and sustained, could help a country advance along the strategic direction. There is a projected shortfall of 18 million health workers by 2030, primarily in low and middle-income countries. And the World Health Organization estimates that nurses and midwives represent 50% of this projected shortage. WHO has even identified 13 urgent health challenges for the next decade, and investing in nurses will strengthen health systems worldwide. The investment in the power of a nurse leader will impact a large sum of the total global health workforce. That is why nurses should be educated and trained to conduct relevant research and to translate research findings into practice to promote best practices and improve health outcomes. Nurses are also called to become leaders and raise their voices in the policy-making table. They need to be leaders in their own profession and in the multidisciplinary team. Nurses need to be involved in policy development. They must be active rather than passive to shape the present and future of the nursing profession and to influence and lead policy. It is important to highlight the responsibility of policymakers in governments, health facilities, and health organizations to support and strengthen the nursing workforce, which is the backbone of the health systems. Investing in nurse leaders ensures health for all.
Okay, Dr. Gordon Gallier, Director Michelle Ramsey, experts, colleagues, good afternoon. It's the 30th of November 2021, and it's my honor to host the third webinar session of the Global Health Nursing Leadership Program. This program was developed by the World Health Organization Collaborating Center in Nursing, the University of the Philippines Manila College of Nursing, and the Peking Union Medical College School of Nursing, developed as part of the celebration of the International Year of the Nurse and Midwife in 2020 and the Nursing Now Challenge. To our participants, majority of which are nurses from the Western Pacific region, welcome. Our third webinar will introduce you to policy and advocacy in addressing global health issues. Please react with a thumbs up to express that you are doing okay despite the challenges of this pandemic. Okay, there we go. Thank you all. My name is Zhang Yun. I'm the Acting Director of Division of International Cooperation of the Health Human Resources Development Center of the National Health Commission, China. And my center is also WHO Collaborating Center for Human Resources for Health. And I will be moderating today's webinar. Let me read some reminders before we proceed to our discussion on policy and advocacy. Please turn on your microphones and videos off if it is not your turn to speak, as a courtesy to our esteemed speakers. And kindly make sure that your Zoom name reflects your full name and your country. To view and share the live stream of this webinar, you may use the links on your screen. They will also be shared in the Zoom chat box. The recording will also be shared with you following the event through WeChat. Let's begin the program by welcoming Professor Huaping Liu, Professor and Director of School of Nursing, Peking Union Medical College, WCC for Policy Making and Leadership for Nursing, to give us her opening message. Welcome.
Hello, nursing colleagues. I'm Huaping Liu, Professor of Peking Union Medical College School of Nursing and the Director of WHO Collaborating Center for Nursing, Policymaking, and Leadership, host of this program. It is a great honor for me to welcome you all to Module 3, Policy and Advocacy of Global Health Nursing Leadership Program 2021. I would like to thank the University of Philippines College of Nursing, WHO Collaborating Center for Leadership in Nursing Development, and the Health Human Development Center of the National Health Commission of People's Republic of China for working with us to provide nurses with this great education program. We had amazing speakers in the past two modules discussing a range of topics, from the current COVID-19 pandemic to the strategic directions on how to strengthen nursing and the vital role of nurses in achieving UHC and SDGs. We also discussed strategic leadership and the management practice in global health and how we transfer and develop nursing leadership to fill in with the fast-changing global health landscape. Our two speakers today, Dr. Gordon Gallier and Ms. Michelle Ramsey, will further expand on this concept and discuss on the topics of global health policies and how nurses feel fundamental in policy making. Nurses' involvement in health leadership and public policy making will help to ensure that the important and highly relevant nursing knowledge is fully used in transforming care that impact the health of nations and contribute to improving health worldwide. I'm glad to say there are over 1,200 nurse colleagues across our region registered in the first two webinars. We are expecting more nursing colleagues to participate and benefit from this program. I'm sure by the end of today's lecture and by the end of the program, you will all have a great understanding of nursing policies and leadership that will benefit you in your career, advance nursing profession in your countries, and contribute to the improvement of health in our region. Thank you, and I hope you will all enjoy today's presentations. Hello, nursing colleagues.
Thank you, Professor Huaping Liu, for your opening message. Let's move forward to our first speaker and the topic. A kind reminder to our viewers to feel free to enter any questions you concerned in the Q&A box in Zoom or through comments in our Facebook Live. We will have the opportunity to discuss them after each of the talks of our esteemed speakers. Our first speaker is here to share her expertise on advocacy. Our first speaker has been awarded a University of Technology Sydney Human Rights Award, Social Inclusion 2014 for her work in the South Pacific. Please welcome the Director of University of Technology Sydney, WCC for Nursing, Midwife, and Health Development, Director Michelle Ramsey. Welcome.
Thank you very much, and I hope you can hear me well. My slides are, of course, going to play up for a second. There we go, here we go. So thank you so much for inviting me today. It's very exciting, and I'm not sure what time of day it is with you around the region. I sit on the land of the Darubin, so I must acknowledge our Aboriginal colleagues here in Australia, and it's a great pleasure to sit here on the mighty Hawkesbury and acknowledge elders past, present and future. So our work within the WHO Collaborating Centre at the University of Technology has been in genuine partnership with the leaders, the Chief Nursing and Midwifery Officer leaders from the South Pacific since 2004, where they asked us to be a collaborating centre. I always think this quote's a really good quote to start with when we're thinking about policy development and working together. Albert Einstein said if we had 1 hour to work through a problem, we needed to take 55 minutes of that hour to work out what the problem was, and then 5 minutes to look at the solution. And I think what that tells us is we need to do a lot of pre-work before we even start working out where we want to go with something. The premise and the area I work in the region, and a lot of the work we do from our collaborating centre, is regarded as international development research. And we sometimes have a problem with something called action bias, where everybody wants to solve a problem really quickly. We don't always look at the cultural context. We don't always work in a collaborative, co-designed way with our partners and stakeholders. And we're often quite working in a transactional leadership rather than transformative. Transformative leadership is about longevity, sustainability, and that's where we're trying to aim with all of our work that we carry out. So I'm sure that our next speaker will speak more about this, because he's talking, he may not, but he's talking about policy development. But certainly within the Pacific, it's something that we highlight around anything we do. Any policy or project should follow the SMART directions. That's to be specific and simple, to be measurable, to be achievable, to be relevant, and to be time bound. So keep it really tight. And I'm not going to go into these too much, but I will mention them at the end if you miss it from this slide, because I think it's a really good reminder when you'll carry out any work to keep it in this SMART format. When we do any work within our region, we want to make sure we understand the context of the work. So some of the work that we've carried out within the globe and the region is looking at anything we do has to fit within this integrated framework. We have to look at everything from a governance context. So is there a chief nurse in the country? Who's running the show? Where are the governance structures in any process? What does the education look like? Is there quality education? And with us, is there associations that can support us for continuing professional development? What are the regulation processes? Obviously, for us and most of the world, regulation processes are really focusing around protecting the public and ensuring that us as health professionals are regulated and doing everything within our competence. So it's a nice framework to think about. And as you will know from all the work around the strategic directions for nursing and midwifery, that really follows some of these dynamics too. So within my context, working in the Pacific, this is a map that shows really what the Pacific looks like. And it's not really a surprise when you look at this map and you see countries like Chile, the US, Canada, Russia, China, that the Pacific is such a political dynamic because it sits in the middle of all these countries. So it's always a really good reminder to understand what the context is of any work you're doing. Within our region, there are 22,000 islands, 8 time zones. It covers an enormous part of the globe, but it also, the health workforce in our part of the region are 74% nurses and midwives. Another example of showing context is when we look at a health workforce against the 4.5 per thousand that WHO says we need as a baseline to achieve sustainable development goals and universal health coverage. And if you look at that map, you might think that Tokelau has the same health workforce as Australia. And Tokelau is a very small island in the middle of the Pacific that it takes 2 weeks to get to from Samoa, and they literally only have 13 midwives. So it's really important that we drill down into the context and understand all the data that's being presented to us. Otherwise, this map could look like Tokelau has the same health workforce as Australia. When we look at the globe and the State of the World's Nursing Report, we know that we're looking at around 59% of the health workforce globally for nurses. And yet again, in our region, 73% of the health workforce are nurses in WIPRO, 74% in the Pacific. And yet we are a 95% female profession. And in our region, it's quite interesting to see that 51% of us are under 35. So we have a very young female workforce. When we look at other literature and we focus a tiny bit on COVID, which I'm not really focusing on, it's really important within our region. There is a lot of things that really were problematic for the Pacific. They have very limited ICU. But equally, they've had quite a lot of experience. Samoa, for example, lost 1/5 of its population in the Spanish flu. So when the pandemic came in, apart from a few countries, the Pacific countries shut down very quickly. And 11 of them have not had any COVID or 1 or 2 cases. So apart from Fiji and Papua New Guinea, where we work a lot, which are really struggling, the Pacific has really been tight around some of the areas. There is still a lot of vaccination fear and misinformation. So understanding our context is really important. Other areas within the Pacific that are interesting are that there were not many labs at the beginning or any way of testing for COVID. And also they were affected at the beginning with many disasters. So they were having many other problems as well as looking at the COVID. WHO set up a regional action plan. And if you haven't looked at that, it's quite a useful guideline for COVID. Within our centre, we worked across the Pacific and in strong partnership with our Pacific colleagues built a WHO basic psychosocial skills, which I will give you the link to at the end, which is a free online course that has been developed in partnership with Pacific and regional colleagues. Again, just more examples of making sure you understand the context if you're trying to build any policies and understanding some of the issues. Again, within the Pacific, there are very few educational courses, even though we cover 74% of the health workforce. So the next area we need to look at when we're developing policy in partnership with our colleagues is look at high-level strategies. What is the hook? What are we aiming towards? What are the areas of the policy that we're going to develop with our partners? And we know all of these different strategies, and I'm not really going to talk to them, but just to allude to the fact that there are many different strategies out there, and it's often really important to know which ones we need to use. The universal health coverage movement, these 6 areas that were highlighted before the declaration was approved, are quite useful. And number 4 talks about upholding quality of care, and certainly use nursing and midwifery as an example in there. I wasn't sure if I put this slide up, but I'm quite proud of this moment. I was it's sort of an example of always take an opportunity. As I was invited to an Australian Commonwealth meeting when the UN declaration was about to be approved by the UN in September, and we went to a big meeting with the Australian Commonwealth government, and they were asking the communities what they thought about the declaration. There weren't many health professionals in the room, and I was there from an NGO point of view. And I very quickly realized that 4.8, where it talks about the 18 million health worker shortage, had missed some crucial words. In the original information, it talked about nurses, midwives, and community health workers from the number 4, quality. And in some negotiations and discussions with Australia actually proposed to put those words back in. And I did speak to ICN and Nursing Now and others. And it was really exciting to see when the declaration was finally approved, those words have gone back in, that we've got nursing and midwifery back in there. And this 2.3 and the UHC declaration is a really important one to use when we're developing policies, because it clearly articulates that we need to retain and build a skilled health workforce to achieve universal health coverage, including nurses, midwives, and community health workers. I know you've spoken about this before, and it always highlighted at the beginning, but again, the strategic direction for nursing and midwifery is really important. It's the first strategy we've had for nursing and midwifery that has been mandated by the World Health Assembly. So all of our countries around the world now have to respond to this strategy and answer to it. So we have a really clear mandate as countries across the globe to respond to the 4 priority areas within this strategy. And they are, as you know, leadership, education, jobs, and service delivery. Just as a highlight there, we also have a new WHO community of practice that I'm sure you've all picked up on and I'll speak to at the end. The next component, so we've gone context for a policy, we've gone around high level a hook to put of what sort of strategy are we putting our hook on? Do our ministries of health have an area they're working towards in in sustainable development goals or universal health coverage? What is the hook that our local areas, and it might even be a small hospital, that the manager of your hospital has to achieve something. So you've got to find what they want as well to get that policy hook. To be able to have a genuine policy, though, we need to map and make sure who the policy is for. Who's the audience of our policy? Is it for nurses? Is it for our health minister? We need to be really clear about the audience for the work that we're developing. And to be able to get to that stage, we need to map that. And mapping health work, mapping stakeholders is it's quite a complex a job, and it needs time. So you need to work at all the people that this policy might affect and spend some time with colleagues looking at the mapping of the audience and the stakeholders. You also need to set up a steering committee, often, or a small committee in your environment, and again map who the people either will be on that committee or will influence that committee, and all the different structures. This is some work we're doing in Papua New Guinea, and it's quite complex. We have a variety of program partners. We have a variety of subcommittees that we've established around the subject area we're looking at. We've got a whole variety of legislative partners and ministerial partners. And down the side here, we've got the key stakeholders. Who are the key stakeholders who will be influenced and we will work with in this project? So partnership is really important. How do we ensure our partners are really on the same page as us? A lot of the work we've done within the Pacific region shows that if we go in too fast and we don't have genuine partnership, we will not actually achieve the work we're trying to do, and the policy will not have its impact. So taking some time to work out who those partners are and bring them on board is really, really important. Otherwise, all we are achieving is a top-down approach. To be able to do that, we might need to look at some of the behaviours, values and norms of the partners or the audience that we're trying to put that policy together with. And that's, again, a little complex, whether it's a community group or nurses. What are their values and norms? We need to work through some of those things to make sure our policy is actually meeting our audience. We've done a lot of work in the Pacific around, and the Collaborating Centre around, looking at different cultural dynamics. And I'm not going to talk to this too much, but I think it's really important to know that within our region, an individualistic approach versus a collectivist approach is very, very different. So that even donor organisations might be coming in, or funding organisations trying to achieve something that doesn't meet the local context. And I think it's really important to look at some of the literature around this to understand the different cultures and values of the partners that we're working with. Again, we've devised a methodology within the Pacific that combines partnerships for the Pacific. And we're very aware that research can be problematic on occasions because it's a very colonial approach and can go in and take information if it's not developed in an appropriate way. And so what we've done is sorry, this slide seems to have a recording with it, so it seems to be taking over, so sorry. Kakala is a Pacific collaborative approach that we've used, and also Talanoa is a Tongan approach. And again, this is a really important way to look at collaborative partnerships in the Pacific around ensuring that everything we do is in line with the partners we're working with. This Talanoa looks at being not over smart. It's about sharing information and really understanding the context. If you look at this lagoon, it looks quite beautiful. You might want to jump into it, but actually it's full of E. coli. So it's definitely not something we'd like to jump into. So it's really important that we really understand the context. If our colleagues have taken 2 or 3 days to get from an outer Pacific to join us for a meeting or discussions, we definitely don't want to only have an interview with them for a few minutes. We need to give them time. We need to make sure we have a safe space to sit down and discuss with them that's confidential. I'm sure in many of the areas you work, people talk, so it's really important to make sure we have a safe area, that people feel safe to share their discussions, so that when you're building those really genuine, trusting relationships and partners with stakeholders, you have an opportunity to have mutual trust and build that relationship. This work has further developed what we're calling a partnership principles, and many of you may have seen the WHO Wipro's vision for the future. And within that vision, they talk about a variety of new operational shifts. Our regional director, Dr. Kasai, has been quite keen at working in a different way in the region. And one of the things he suggested is looking at something called backcasting. If we want to get somewhere in 20 years, how can we work back from that period? Another approach in his operational shifts he's talking about is a grounds up approach. I think as nursing and midwives, we're very good at a grounds up approach. We've always worked in that way. But I think in research terms, we've not always been very good. Some of our approaches, as I've already said, are more top down. And so this methodology that we've developed within the Pacific will further build on this. And we're now building some partnership principles following this grounds up approach. And some of these partnership principles have come from this body of evidence, and they talk about safety. Do people involved in your policy development and who you're working with feel safe? Are they able to speak up? Respect. Are there the partnerships grounded, and is there an understanding of what the gaps are from both partners, so that there's a respect for decision-making processes and discussion from both partners to identify and address gaps? Collaboration. Are the project or the policy planned and designed and evaluated in true partnership? Is it a true collaborative approach? Does everyone feel involved, from the association, the regulators, the educators, our governance partners? Reciprocity. Will, at the end of the process, everyone own the results? Is it developed at a timeline that makes sense to everyone? Will everyone be able to work together to actually develop this work and have an understanding that makes sense from them and whoever's working out? Justice is really, really important to develop and make sure that the outcomes sit within all the cultural mechanisms that I've discussed, that we do it over time, that it's built at the timeline of all the partners. It's not rushed through in an action bias. Everyone's trying to push something through. It's done in a period in time that is able to ensure that the process and policy is building sustainability. And obviously, relationship-based is something that's really, really important, that it's built on compassion, empathy, and appreciation for context. However, this is a little note to myself, beware, because the next slide is very busy, so it's just apologize now. This is going back to our model right at the beginning, and when I say that we make sure that we do everything within these lines, that it's almost a mapping, it does become complicated and busy to develop any policy or piece of work. To involve the associations is really important, to involve the policies and process and strategies and partners and our educational colleagues. And longevity, the top picture I absolutely love is a picture of myself. Can you hear me okay? Yeah. Yes. Myself with the previous 4 chief nurses of Tonga. So very lucky to have worked in Tonga and the Pacific for so long that over a period of time, there is a genuine relationship and sustainability over many times. So what I'm trying to say is that this process isn't easy and does need some planning and time to get through. Finally, I just really wanted to talk a little bit about perseverance and your self-care. To achieve this work, and we know especially during COVID, we need to persevere, but we also need to look after each other. We need to support each other, we need to be honest with each other, and we need to look after each other, because we'll only get there with perseverance. But we can only do that if we walk the talk. And I mean, a lovely picture for me of Elizabeth Iro, you know, in true partnership with ICN and WHO in Geneva one time. But genuinely, we really, honestly need to care for each other and look out for each other. So I really don't want to take too much time on this, but just to highlight a couple of areas that we've worked on in the Pacific using these philosophies. And certainly this is a really big piece of research that was carried out around the impacts of climate change on health. And it was a huge piece of research across 4 or 5 Pacific islands with lots and lots of outputs. But I think what's more important is that our Pacific colleagues turned that research into a frangipani model that they could sustain, that they could understand, and it was a translation of this research so that it actually makes sense within the Pacific. And this can only happen if you have this true relationships. The other work that I alluded to at the beginning is this beautiful piece of work, the basic psychosocial skills, education and training. There are all the resources here. I'm very happy to put them in the chat afterwards and share. And it's a very nice free program that you can either work through with your colleagues. There's a whole variety of resources that goes with this program. We've carried out leadership programs within the Pacific for many years with our colleagues. And that has led to some really lovely outcomes of 85% of our colleagues having career development. We have 2 ministers of health out of our program and many, many colleagues presenting and working across the globe. I didn't really want to say too much about this slide, apart from the importance, as we've highlighted, of all the entities that can support us. Whether it be the International Council for Nursing, whether it be the International Confederation for Midwives, whether it be what's happening at the World Health Assembly. Within our region, we're always aware of the Pacific Health Ministers meetings, because if we can get something on that agenda for nursing and midwifery, we can genuinely push things forward. But it's really important that you understand your regional context and your frameworks to push resolutions and things through. And that's why we're so proud that the strategic direction for nursing and midwifery has been approved through the World Health Assembly, and we are now mandated to use that globally. I don't think I have many more slides, and it looks like I'm a little fast, but I'm sure we can use that up with the conversations at the end. And again, just wanted to make sure everybody knew about this really fabulous resource. WHO headquarters, through Liz Iro's leadership, have set up this global community of practice. The link is here, and I can share it again in the chat. And this global community of practice is a global community for leading nurses and midwives, but partners and anyone. There's a whole variety of resources on there, and we're really trying to build this community of support around the world to support us all and learn together globally. I guess the last one was a little bit of fun, a little bit of revision about what we've been doing. So happy, my little happy. hook. If you're producing a policy, what's the hook? What's the thing that's important with your government, your manager, your association, or globally? What's the hook that you're trying to put your policy on? What's the audience? Who's the audience that you're trying to put this work together for? Who are you actually writing the policy for? Partnership, making sure that you have strong, genuine partnerships. Otherwise, it really isn't going to work. Perseverance, the perseverance and push and passion to keep going, to try and achieve and build something. And finally, as I said before, really, really, really important in these current times, look after yourselves, work with others, don't try and do it alone. And just to remind us about the SMART, you can look that up afterwards, the SMART outline to get policies off the ground. And thank you very much.
Thank you so much for Director Michelle Ramsey's wonderful presentation. And you give us a very brilliant speech from the perspective of the strategic and advocacy. And your happy and the smart principles are quite impressed. Now it's an open forum session. We will now take questions for our speaker. If you are a panelist to this meeting, as a participant to the Global Health Nursing Leadership Program, yeah, you can just directly turn on your camera and wave your hand and ask the questions live. And for the other viewers, you can also input your questions in the Zoom Q&A box. Now I have collected several questions. Shall I ask them on behalf of the viewers first? I'd like to take the advantages of asking the questions. And the first one is thank you for the grounding policy and advocacy of understanding contact, identifying the hook, and mapping the audience, Michelle. For new nurses in leadership roles, one major challenge is establishing genuine partnerships, most for working in silos. Do you have any practical tips in networking and partnerships? Thank you. This is the first question.
Yes, I think it's really, really important. When I was a young nurse, I was what was called I used to read all the notice boards. Any notice that went anywhere, I would read the notice board and I would see what was happening around my hospital, my environment, and I very quickly became a Royal College of Nursing trade union representative to support other nurses and build partnerships within my hospitals. Now, today, we don't have so many notice boards, but I think there are many other ways that we can connect. Some of the platforms, Twitter, WeChat, a whole variety of platforms are available. And if you're clever and connect regularly and look out for people you like and admire, you can find out very useful, quick information. But also use your local associations or professional groups. Build together groups. If you find somebody that you're working with locally that has a similar dynamic. We are so used to Zoom now. Set up a Zoom with other colleagues and have a chat. Just support each other. I know we can't always get together now face to face, but there are many ways that we can connect. I recently was very lucky to connect with my nursing colleagues of 40 years. I've been in nursing 40 years, and we had a celebration this year from all around the world. So don't be afraid to reach out and organize something yourself. It takes a little bit of bravery, but we can all do it.
Okay, thank you. Very informative and useful suggestions. And the question number 2. One of the major challenges is involving nurses in policy development. In the viewer's country, we have policies that don't necessarily reflect actual contact. How have you worked with the legislative bodies to ensure that policies for nurses capture the real needs?
It's extremely hard and it takes a long time. And that's why I was trying to say that model of working out who is around to support us is really important. Do you have an association in your country that you can work with or support? Because they often need help. Does that association speak to your chief nurse? Do you have a nursing leader in your government that you can work with? We may not have a chief nurse, although in our region we're quite lucky. We have 27 senior nurses in government in the 37 countries. But who is that person? They are often isolated. And how can we work with the associations? It takes a long time. I know in Korea, they have just finally got some nursing legislation off the ground, and that's taken them a long time. They've had their first nursing leader in government there forever. But they've worked very, very hard behind the scenes. So it does take a long time. And that's why you need to build your groups together and work together. But if you have an association, they would be really happy for your support. And there are many ways. And I think that's why I was so excited when the universal health coverage names nurses, midwives, and community health workers, because in that UHC, Universal Health Coverage Declaration, now we have some lines that says nurses and midwives are very important to achieve that. Make sure you find those words. The other thing that we do within our region is we teach data literacy. You do not need to be a researcher to share data or collect data. You just need to understand the changes that are happening around you and share that data with colleagues, either just up from you as management or the next leaders up. Nurses are often collecting the data time and time again, right from the bed, right in the ward, right in the hospital, but they don't always take that data on board and look at it from 1 week to the next, from 1 year to the next, and start to see if there are patterns, because those patterns give you power to actually be able to put into policy and persuade people that they need to make changes.
Okay, great. Thank you. And I also hope that the nurses' voice can be more heard by the top authority. And the third question, I see the grants-up approach involving the community consistently. I'm afraid in our country, this active contribution is hard to sustain because some communities lack unity and it's hard to come up with ethical incentives. Do you have any good practices to share to implement community empowerment?
It's really hard. I mean, I think we could say the same for nurses. Nurses are not very good ourselves. We often have so many different silos within nursing. We're not always very good at working as one voice. I know that we often joke that our medical practitioners are a little better than us. They will go into a room and they will have a little fight about an issue of concern and they will come out with one voice. We often go to a meeting and we all say something different. So I think we as nurses also need to learn how to work together. I think community voice is really important and I think it's really hard. And I would really go back to that hook. If you can find a common area that the whole of the community wants to work with, it will be easier to have those discussions if you can find the thing that is important for all of them. Because while we all come in with different opinions and approaches, it is really, really hard to move forward. So it's trying to talk to people individually and find that one common area, then you can build the policy together. I hope that helps.
Okay, thank you, Director Michelle Ramsey. It seems that from our audiences, they still have a variety of questions to ask you. Maybe later, we still have time for the open discussion. Thank you again, Director. Okay, now we move to the next speaker. We will connect what we have learned in advocacy into policy. Today, we have the honor to have this second speaker with us to share his expertise on health policy. On behalf of the Western Pacific region of WHO, he has been coordinating an effort promoting innovation in public health within the For the Future vision of the region. We are pleased and very honored to welcome the WHO representative to China, Dr. Gordon Gallian. Dr. Gordon Gallian, it's yours.
Thank you. I am, can you hear me? Can we do a voice test, please, Jang Yun?
Perfect, yes, perfect.
And
I can hear you.
My screen?
Yeah, we can see it.
Super, so thank you to everyone and a big thanks to both colleges, PUMC and UP Manila. I have close associations with both, and I'm very, very honored to be invited to be presenting here. I'm very happy, and thanks to Michelle for that switch, because she sets a splendid context for the ideas that I will be talking about. A large number of slides in a small amount of time. I will share my slides, please then use them at will. But I take this one anecdote from Michelle's presentation, where she spoke about being on the spot to influence a decision that was being recorded at global policymaking level, and making sure that there was a specific aspect of the policy. I'm generalizing the story because you heard it in detail from Michelle, but it is a great example of how global health policy making is indeed taking place. Even as we speak, yesterday, a special session of the World Health Assembly started. I really encourage everyone to read the powerful speech that was made by Dr. Tedros, describing the importance of having a pandemic treaty. And the importance of such documents is that they lay down the foundations of how countries cooperate, of how countries act within their borders. And I take these 3 points as the brief that was given for my lecture. I will very rapidly set the scene and identify a few practical points of intervention, and I will largely focus on the policy arena for global health policy making. So what does that mean? We know we are all looking forward to the attainment of the Sustainable Development Goals. The pandemic has, and we're all working within goal number 3, but we know very well that goal number 3 is deeply embedded in so many other areas of policy. Poverty is a great determinant of health, hunger, education, gender equality. So there is no sustainable development goal that is not connected to health. So there's this bi-directional approach. So by working in global health policy, nurses can influence the whole of human development. And Michelle already mentioned the instrument that we have in our region for implementing the Sustainable Development Goals is this For the Future vision, with its 4 thematic priorities and 7 operational shifts, including universal health coverage, including grounds up, backcasting, and innovation. Moving forward, one of the questions when I talk about global health in a nursing arena, and I have done so recently with a group of nurse educators, it was very clear to me that I needed from their reaction to answer the so what question. Why should we talk about global health for nurses and nurse educators? And I do this humbly. I realize that, yes, nursing is a female-dominated profession, and certainly I'm a physician by training, so I am an outsider on 2 points. I will look forward to the discussion if you disagree with what I say, but I suspect you won't. 59% of the health professions of the world, according to the State of Nursing report, are indeed nurses. And we need to, therefore, one of the big aspects of global health policy making is to embed global and planetary health in the teaching of future nurses. We are automatically reaching almost 2/3 of the health professionals of the future if we have good global and planetary health for the nurse within a nurse educational setting. And I love the title of this paper, which I commend to everyone, Teaching as if the Future Matters, bringing in issues of advocacy and leadership from the early days of undergraduate training. The paper embeds global health competencies within a nursing competencies framework, focusing on social justice, holistic care, advocacy, health as a human right, sustainability, collaboration. And therefore, with 4 different foci as being the assumptions that bring us into the achievement of these core values and principles. I commend this paper to you, especially the nurse educators among you, because it gives you a very detailed framework on which to build curricula and indeed to have a discussion on what the global health arena looks like. The Global Nursing Report has been mentioned many times. Clearly, the nursing situation itself around the world is a major issue in global. It's not only, it's a sort of, it's both an impediment to nurses participating in policy, but it is also a policy issue itself. Huge inequity in the distribution of nurses between developed and lesser developed countries, but also an issue in the more developed countries where it may be that in our region we have a young population of nurses, but also in parts of the world there's the opposite of that, with aging workforces generating their own deficit and becoming an issue of how do we support nurses as they nursing profession as it ages, how do we generate new recruits without necessarily drawing just the young brains from other countries where they are even more needed. The State of Nursing report has many key findings that have been covered already, so I will press on. It ends with 3 sets of recommendations, and I focus on the last one. A focus on global and planetary health is a focus on nurse leadership for both the current people who are regarded as leaders within the profession, but also in the training of future one. So we need to ensure that nurses have an influential role in health policy formulation and decision making, and that they contribute to the effectiveness of health and social care system at national level as well as at international. Now, what is the scope of global health? Because there are many words that are used to describe this. And if you look up the literature superficially, you will possibly get confused by words like global health, international health, and planetary health. In this slide, I have tried to summarize the findings or the arguments of 2 key papers. So this one slide with its 2 references gives you quite a good entry point into the discussion on international, global, and planetary health. Generally, we have, I put them here not in the order that they appear in the various tables in those two papers, but in the historical order that we have seen them evolve. So the global health arena developed as an international health issue. For example, a rich country wanting to help poorer countries, therefore developing a policy of aid to bring money and grants and technology and skills into a context where these were in deficit or lacking. Countries interested in how to control the movement of goods, services, or diseases across their borders. So these tended to be the issues related to countries working together across borders, often involving arrangements of a bilateral nature or a multilateral with a few countries being involved. That evolved into a global health framework, which focused on issues that require global cooperation. If we take an example here, the Framework Convention on Tobacco Control is an issue that required a treaty to be set up between all countries of the world, defining both the demand and the supply-led measures that can be used to control tobacco. Tobacco is an issue in one country. You have growers of tobacco. In another country, you have importers of tobacco leaf and manufacturers. In another country, you have a transnational company that is promoting and selling, including back to the original country, selling cheap cigarettes to recruit new smokers in the developing world. The issue of tobacco, yes, is partly an issue of helping individual people, say, to stop smoking or to stop the recruitment of new young smokers. But in reality, the tobacco control movement is a global movement and required a global treaty. Beyond global health, more recently, people have been talking about planetary health. Issues that are typically discussed here include, for example, climate change, the whole climate change agenda, carbon emissions. We are all responsible for our own carbon footprint. Countries are responsible for their own emissions. We all face the consequences in the short term. The next generation faces the consequences in the medium and long term. And it is a problem where we may render our planet uninhabitable to humans, if not to a whole range of other species. So it's an existential issue. We will get back to the One Health, but I am already overrunning. I ask you to have a look, and maybe we can come back to this during the discussion. My friend Martin McKee presents global health as a sandwich. I call this the sandwich model. So when we think about global health, there are these 5 components. At the base, there are the core public health consideration. At the top, the face of global health today is really as an element of foreign policy. And the instruments or the areas of concern vary depending on what is the thematic concern that we are talking about. But key issues that always arise are issues of security, issues of trade, investment, and of aid. And I will have, for the rest of my talk, I do not know how much time I have. You will please indicate in the chat when the time comes. I'm going to give you a very quick sampling of these five as the definition of the global health arena, with some pointers on policy making. So global health is public health, number one. And I take us back to For the Future and the Sustainable Development Goal. Here we have a whole series of 17 issues for nurses to get involved in ways that, using the happy framework that Michelle presented earlier. Congrats to her. I will use that as my mnemonic from now on. Perfect. She chose the document on 13 threats. I go back to the year before the pandemic, where WHO was focused on 10 of these threats. And already there are echoes of issues like vaccine hesitancy and weak primary healthcare and fragile and vulnerable settings. These were threats that we were noticing in 2019, and we are paying a very high price, and people are paying a price in high mortality based on that. Each of these is an area for nurses to get directly involved. And for reasons in the framework that I have already mentioned, there are so many reasons for nurses who are at the front line of so many of these issues, for nurses to get involved, not just with dealing with them at the clinical level, but for taking that experience back into into national and global policy making. I'm hoping that people can see this slide. A recent report came out of the European region of WHO. It was led by the former Prime Minister of Italy, Mario Monti. It was therefore called the Monti Commission. The link here can take you to the full report, which includes a call to action, an evidence review, and the report. And you can see summarized in this picture so many keywords that, to me, represent the post-pandemic global health agenda. At the core is One Health, which brings together animal, human, and ecological health, surrounded by 4 key pillars that, in order to face this and the next pandemic, we must work towards inclusive societies. The Pacific examples that we saw before are so relevant to this discussion. We need to talk about global public goods, everything from patents to provision of vaccines. We need to talk about innovative health systems, how to draw in digital health in a way that reduces the digital divide, increases the safety, quality, and effectiveness of health services, and to reform the global financial system. Look what happens. A country like South Africa identifies a new variant. It pays a price for that. Over the years, countries are going to learn the lesson that you should try and hold back on data because you will pay an economic price. And therefore, some way, for example, of compensating countries who have been good global citizens should be embedded in the global financial system. We need to be imaginative in all these 4 pillars, and why not? Nurses need to have a voice in all of this. So much time could be spent on this global risks report. Every year, the World Economic Forum produces a report on what are the risks that are being faced by the globe, by the world, as we face in the current situation. And these risks are ranked from low to high likelihood and from low to high impact. For the last couple of issues, I have been privileged to be part of the panel. They draw in a panel of hundreds of experts from around the world. Each of us has to assess a large number of risks. And I told myself as I was making this slide, how many nurses are actually on the World Economic Forum panel? It would be interesting to know, and it would be interesting for nurse leaders globally to reach out to the World Economic Forum and to discuss. I can see Michelle nodding, and I'm glad we are sparking across the across. I think from my point of view, if this same exercise was done by a group of nurses on the front line, I wonder whether things like mental health deterioration, can you see how low it is in both in terms of likelihood and impact? Is it true that it is both of moderate likelihood and of low impact during this? I think nurses would have a deeper and more accurate insight of this. I will add to Michelle's happy, and I link you here without going into the details because I still have a lot of slides to show. You will see many policymaking frameworks. This one from CDC is a particularly accessible one. In Einstein's quotation that Michelle started with, you have 55 minutes of assessment and 5 minutes of action. And indeed, this model is very much the same, because if you look at this model, stages 1, 2, and 3 are all about assessment. And then it is only at 4 and 5 that you are enacting and implementing policies, at the core of which is stakeholder engagement and education, so many examples of which we saw in the previous speech. But one model that I like to use, and I'm happy that Michelle didn't include it, because at least I have also something to add, is Kingdom's nonlinear framework for policymaking. Let us imagine that this blue arrow represents our policy journey. We want to go from a place, for example, where nurses are excluded from policy making, to a place where there is a policy that nurses must be included in all health impact assessments for new policies that are being planned or formulated in a country. Kingdom suggests that in order for us to go from our current place to a future desired policy, we are impeded from making that journey by the health problems themselves that we are facing, the policies that are in place at any point in time, and also the politics, how politics and policies interplay with each other in our context. So it may be, if we take a very current example, the problem might be pandemics and the dangers of pandemics. The policies might be the international health regulation that lies in place, but we are seeing the need for a pandemic treaty. The politics is how do different member states think about this, and how do they, how willing are they to work together to formulate such a treaty? And it is actually, you can look at the journey, therefore, that we have to go to from now to developing the treaty as being impeded by these 3 layers of barriers. And Kingdom suggests that there will be windows of opportunity which we need to work to align and find the moment when we can make the journey. Now, it's easy to do on a PowerPoint slide, but I think it's very difficult to do in the real world. What it does say is that we need to find the opportunity. We need to look for moments when you happen to be on the delegation and you happen to be with people who are willing to listen to you, and you're able to get a phrase embedded in a document that then ends up being agreed as global policy, and then hopefully enacted. But I think that that's one possible depiction of the journey, and I like to think of Kingdom because this is not first you do, and when I think of the CDC Polaris approach, it makes you think that you're going around in a circle step by step. But Kingdom reminds us that we have to take that policymaking is also opportunistic, putting yourself in the place where policies are made. Global health as trade and investment. And so much can be said here, but the language of investing in health actually is, to an older man like me, is quite recent, but to many of you, it may be coincident with your high school or middle school. But in 1993, World Development Report from the World Bank first brought forward the idea of how do you formulate health policy in a country. And investing in health wasn't about giving aid, it was about how do we use money wisely to get the best value for our health investments in a country. And so they developed the idea of developing burden of disease studies and then investing in those interventions that were most likely to reduce that burden of disease. That approach was echoed a few years later by the commission led by Jeffrey Sachs under Gro Harlem Brundtland, who was then the DG of WHO, with the same title. Obviously, it was a response, but also an extension, looking at the macroeconomics and health links, and making the argument that were a number of, at the global level, there were a number of conditions like neglected tropical diseases that were holding back human development, and that investing in health was a macroeconomic global health agenda. But even both those documents left out what is the predominant cause of mortality and morbidity, and that is the I have 4 minutes to speak. Non-communicable diseases are, I'm using 2 screens, and I don't know how close I am to the end. Non-communicable diseases need to be brought into the agenda, and one of the big issues that hasn't been mentioned up to now, one of the big areas of policy is what is the influence of the large transnational corporations that the makers, sellers, and purveyors of tobacco, alcohol, and big food, indeed the high prices of pharma, the commoditization and commercialization of health services. So these are the big commercial determinants of health. Again, nurses need to embed themselves in the context of commercial determinants because they are becoming dominant concepts in global and planetary health. This model in this paper talks about the market drivers, the channels by which the companies work, as well as the eventual outcomes. And this more complicated model talks less mechanistically, but more about the exercise of corporate power. How it's not just the channels, but also the acquisition and the exercise of corporate power and how it manifests itself. I think a formal study of both these areas allows, and this includes, for example, who employs nurses, who moves nurses around. So talking back to the original human resource question that I raised at the very beginning, these directly affect as well the nursing profession. Okay, before I move forward, could you tell me how much time I have left? Or have I basically ended my speaking time?
You may have in the last 5 minutes for most.
Okay, then maybe I will just show you one more slide. This paper is an older one, but I really like it. It struck me very strongly when it first came out. I want to make an issue. I want to raise an issue to the attention of global policymakers. How do I do that? And maybe if you only read one paper, have a look at this one from the ones that I have given, because it does have a prescription of 10 key points that are quite illuminating in terms, if you want to go forward with any issue of global policy, you need to have a movement. And that movement, whether it's concerned with HIV or nursing shortage or brain drain or conditions of work or safety or any of the agenda items on climate change, etc. What is the cohesion in the policy community? Michelle mentioned that doctors come around and they agree with each other. I have seen that happen, but I have also seen the very opposite. I have seen, for example, that when one tries to bring the integrated approach to non-communicable diseases, the cardiovascular team get divided into those who are for stroke and those who are for heart disease. And those who are for heart disease divide themselves between those who are concerned with muscle issues, those who are concerned with rhythm issues, and those who are concerned with coronary issues. And after all those fights are over, then you hear a little voice from the peripheral vascular group and say, hey, why have you left us out? There are so many peripheral vascular conditions that need to be concerned. So the policy community cohesion, we need to have, the more we subdivide our concerns, the more problem we have. Do we have leaders who are capable of uniting the community? Who are the institutions that guide us, and how effectively are they able to guide? Do we have civil society that is mobilized? And is it possible to mobilize civil society in these days of infodemics and misinformation and disinformation? What is the internal frame around which we define the causes and the solutions of the problem? And how is the problem seen externally? How is it portrayed in the public? What are the kingdom policy windows? There's also something called the Overton policy window, which is what is feasible within, what policies are feasible within a politician's framework, within a politician's term of life. What's the global governance structure related to the condition that we are working on? Do we have credible indicators? Is the severity of the burden relative to other burdens agreed upon? Look back at the mental health implications of the pandemic and the World Economic Framework. So anyone who's trying to advocate for mental health issues knows that a panel of experts around the world, please allow me to say that I did not vote low for mental health, and I'm saying this because I was really surprised to see how low it came out. But if you know you're starting on a mental health issue, you know you have your work cut out, because the experts around the world have agreed that it is moderate likelihood and low impact. And what are the effective interventions that we are going to put forward? I have something like 12 slides left. I will leave those to you. Maybe the slides will tell their own story, and I thank you for your attention.
Okay, thank you so much, Dr. Gordon Gali, for your brilliant speeches. And you have opened our audience to the significance and the good practices on health policy. Now it's the open forum. I think from the participants, we have a lot of questions. We have collected some of them. And the first question I would like to ask Dr. Gordon Gali. Thank you so much for mentioning commercial determinants for health. Can you give comments and suggestions on building policies that are smart, which has been mentioned by Michelle, her framework, smart framework, to implement? Because, for example, the policy on universal health coverage may be hard to implement. How is policy implementation considered when policies are made?
Okay, there seem to be 3 questions there. I'm going to condense that into a response on commercial determinants, because there's so much more to say. One answer to that is a paper that we wrote back in 2014, where we present a 5-step process for deciding on how government policymakers can consider cooperating with the private sector. There are many areas where the private sector says we want to be part of the solution, not just part of the problem. They range from food producers to health insurance, private health insurance, and they all want to partner with government, and they all want to show through corporate social responsibility how they are making a big contribution to development. Often this is not the case, and there are a number of tests that we propose in that paper that governments should put forward, and I'll quickly name them. One is look at the do no harm principle. Is the core product or services offered by this company actually promoting health, or could they improve it to reduce the harm that it is causing? Secondly, if they want a seat at the policy-making table nationally or globally, can they prove their credentials by showing how they promote health and protect the health of their own workers, which is a captive audience across all regions, not just doing it in Europe, but not doing it in Asia, for example. At the third level, what is the impact of their corporate social responsibility program? Now, of course, internally, they always have a narrative on how successful and how positive it is, but can they open that up to independent audit and health impact assessment? Fourthly, is the company contributing to global public goods, patent pools, donations of their technology, and so on? And fifthly, what is their own? What are their policy proposals once they have passed through the top 4 questions? The fifth one then is we need to stop corporate interest from coming into the actual policy formulation, but it is having shown that they have earned their credentials, then I think it's possible to work with the private sector on how to administer. So you can't ask a tobacco company whether you should be taxing tobacco, because the company is going to say no. But if you want to tax fats or sugar, then yes, you can make the policy as a government, but then you reach out to the industry on how best to implement that policy in such a way that does not cause harm, or that does not cause unnecessary overheads or inefficiencies.
Okay, great. Thank you, Dr. Galian. And this is the other question. Thank you, Dr. Gali, for clarifying the differences and the scope of international health, global health, and planetary health. On a practical end, national organizations wish to be more involved in policy development. In your experience and perspective, what are the policy areas where nurses are usually not present but are badly needed? Thank you.
A very good question. But to be honest, I really think that I'm here in danger of getting virtual tomatoes tossed at me. Or maybe you will see me. I would almost wish that you hand this question to Michelle. But from my point of view, before I moved to China, I attended every World Health Assembly for the last since 2006 to 2017. I was there at each. I felt that the presence, and in my career, for 6 years, I ran an institute, what was called an Institute of Healthcare, and which included in the university in my country, the nursing school that has now become a very large faculty of health sciences. But in those days, therefore, I was quite close to nursing, and I have always had this sort of nursing antenna. I saw very few nurses on the delegations. I think if there is one thing that can be done, it is indeed to have more. Now, I know, of course, that physiotherapists are going to say the same, and then so by saying this, I don't want to fragment the unity of the delegations, and find that now every profession wants to have its place on the delegation. But I would expect that 59% of the world's workforce is nurses. Then 59% of the World Health Assembly delegations should have at least a nurse present. I think it's a worthwhile, I mean, I'm just giving a rule of thumb. But so what I think nurses are very active on issues like working conditions and pay and occupational health and safety. But their presence and interest in global health and broader public health. I also often am sitting on selection panels for staff within WHO. And so I'm looking for a master's in public health in many of the conditions, in many of the recruitments that I make. But I'm also interested in what is the basic science, what is their bachelor's before. And just looking at the last two, not a single one had nursing as their first degree. It's not because there aren't enough nurses, it's because nurses, I think, maybe are not moving into public health often enough. Is that an issue for education? Is it an issue of working conditions? Is it an issue of socialization in the profession? or is it an issue of us, the organizations who are employing? I think this is open to discussion, but certainly I want Michelle to have her say on this.
Thank you, and I'm very excited too, because the reason we became a collaborating centre was for that very reason. I also have been to all the World Health Assemblies, and I have many pictures where it's just a sea of men, let alone medical practitioners. So we've been very excited through the leadership program in the Pacific, and one of the outcomes was when we finally got to a period when 9 Pacific Islands, tiny Pacific Islands, those chief nurses persuaded their health ministers to let them go. And I think that's huge. WHO has tried all sorts of philosophies. Every couple of years, we have what's called a triad, where we have the chief nurse, regulator, and association at WHO. So that was a really positive mood. So you'd have hundreds of chief nurses, regulators, all these nursing professions meeting before the World Health Assembly. But one year we did a poll, and it was quite staggering to know how many of the health ministers or health secretaries hadn't enabled the chief nurse to attend the World Health Assembly, which was happening the following week, in their delegation. And that's because the delegations are really tight. The health minister, the health secretary, or the medical director often wants 5 or 6 people to support them. And it is really hard. And you're right, it's not just about nurses, it's about health managers, it's about physios, it's about a whole variety of health professionals, because our argument is unless we get a unilateral health portfolio to the World Health Assembly, we'll continue to get very narrow thinking. So I think that's why we've been really excited. The last few years, we've had a nurse representing WHO executive, Deborah Toms a few years ago, and now we have Milia from Tonga, who's also a Minister for Health, but also on the WHO executive. So I think you're absolutely right. We've got to keep pushing that. But I don't know where the problem is, whether it's sometimes culturally within the countries, the nurses not able to ask to be a person. ICN also supports colleagues to be there in their delegation, as does ICM. So we can get nurses into the delegation in other routes. But I think you're absolutely right. We need to really, really keep pushing for that. And I think we're getting better, but we've got a way to go.
Okay, thank you both. I have the other question, but maybe Michelle has just answered this part of that question. And the question is, it's true that nurses should be involved in the health policy making table. Although there are times wherein public health nurses are having a hard time voicing out their concerns, especially in cases where they are at the lowest level of the power hierarchy. How can we empower nurses to take part in the development and implementation of policies in global health setting? Dr. Gali, would you like to answer first?
I thought that was also going to Michelle, but yes, I will. Let's do it like that. I tend to speak at great length, and maybe I can pull up the rear.
Okay, fine. Okay, look, I agree, it's really important. And I think when I worked in the Royal College of Nursing, one of the studies we did was we did a massive study of 300,000 nurses across the UK. And what showed was that only 10% wanted to get involved in either pushing things forward in the trade union, the professional trade union. So it taught me that maybe only 10% of nurses have that power and courage and confidence to stand up. So we've got to recognize that not all nurses have that will or want to be at the policy table. So it's a tricky dynamic, because I've been at many policy tables where even within WHO, I've sat along the wall and I've had to go, oh no, I can sit at the table. I've been invited to this meeting. So I think as a female, as a woman, sometimes we do just have to take that courage and sit physically at the table. When I go out to countries, especially in the Pacific, as a WHO colleague, I make sure that I have a meeting with the Minister for Health, the Secretary for Health, with the senior nurses of that country. Because often the case is they don't have an opportunity to meet with those people. And I do a share and conversation to make sure and we always have a pre-meeting to find out any of the issues of concern so that we can have a group meeting. But even on some of those meetings, I've sat down at the table, I've turned around, and my colleague, the chief nurse of the country, is sitting at the other end of the room. So it's really, and of course I said, come, we're all together, but it's really hard. We just have to work together and support each other because there is nothing else. We've just got to take that courage and make that move. Over to you.
I reinforce that and extend it a little. I would think about it as an emergent pattern. It's not about blaming individuals for not coming forward. It's something that the environment is generating. So the question needs to be rephrased in the form, at least reframed in the form of what are the incentives and disincentives for nurses to be involved in global health policy making. And certainly at the educational level, and again, rotten tomatoes at me, but the nursing is the ultimate person-centered profession. And as we train nurses in our colleges and schools, we are educating and socializing a professional who has the person at the center of everything they do. The nurse is present, the person provides the patient with a holistic picture, while even other professionals, the doctor and the sociologist and the social worker comes in and does their little bit, but it's the nurse that has the full picture. Somehow, an element of that, which values equally what happens at the population, might generate the creativity and the imagination of enough. We're not suggesting all nurses need to go into this area, but of a larger group that are willing to enter the political arena, because public health finally is politics, and that I think is a big issue. How are nurses paid? In some countries, the payment of public health people is really very bad. And so there's no incentive, not even for anyone, doctors, nurses, or anyone to enter the public health field. So I remember my own first approach into public health. I remember climbing the steps into my national, what in my country is the National Health Commission, for the first time, having decided to leave my hospital post up till then, and feeling this wrench. The place was actually winter, dark. I remember the picture very clearly. And that transition and climbing those steps represents for me the transition from leaving the bedside to opening the ledger of the debt registers and so on. And so it becomes a different, a huge incentives. How are we protecting, providing opportunities? How are we paying the public health workers?
Great, thank you so much for your two experts' input and thoughts. I think for even not only for the health, for the nursing group, but also for the physicians, for the health workforce, they should also generate this idea of to be more global centered, and need to think more globally rather than only your technical work. Thank you so much for the discussion and to share us your thoughts, experiences, and especially Dr. Gali, you shared with us your personal history of transitioning from the doctor to an official. We very much appreciate it. And thank you so much. We would like to
thank you all.
we would like to recognize Dr. Gali and Director Ramsey, who have been joining us live and generously answered so many questions from our audiences during the open forum. At this time, may we request all our panelists to kindly turn on your camera for a group photo. Yeah, our technicians will take a group photo. Yeah, shall we just give a thumb up? Yeah. 1, 2, 3, here we go. Thank you. Are you done, Jen? Okay, great. Thank you so much for your time.
Thank you.
Thank you. And as an important part of today's program, we would like to show you 2 videos featuring countries' response to COVID-19 pandemic of China and Australia. The first video is about the vital roles of nurses in pandemic response in China. Please.
China is the first country to lead the fight against novel coronavirus. With a capacity of 2,000 beds, Wuhan, Huashanshan, and Leishanshan makeshift hospitals were built in only 10 days to treat coronavirus patients. The rise of death and rapid spread of the coronavirus does not frighten Chinese doctors and nurses. More than 42,000 medical workers, including 28,600 nurses from over 200 medical teams across the country, had gathered to be sent to Hubei province. More than 5,500 intensive care nurses have gone to the front line of this battle. This number accounts for almost half of all intensive care nurses in China. Fighting on the front line, saving patients, nurses are the heroes in the face of this enormous challenge. Patients with severe symptoms usually have multiple complications and organ failure, which require complicated treatment and medical care. The job requires highly skilled nurses. Their jobs include monitoring patients' vital signs, administering treatments, conducting professional nursing plans, the use of ventilators, CCRT, and ECMO. The international communities have expressed their concerns of the outbreak in China. Ms. Annette Kennedy, president of ICM and many other organizations, have written letter of support to Chinese Nursing Association. Mr. Howard Catton, chief executive officer of International Council of Nurses, also shared a video to acknowledge and thank Chinese nurses for their hard work.
I wanted to acknowledge and thank you, the nurses of China.
In the battle against coronavirus, Ms. Wu Xinjun, president of Chinese Nursing Association, said, "Nurses in China, as part of our medical team, provide patients with professional care. They are working hard with skills and courage."
但是前几天我父母知道了，那是我第一次见我爸父母在我面前，22年来他第一次。
In the battle against coronavirus, nurses are not only our unsung heroes, but also others' parents, children, and beloved ones.
don't know that I ever received formal training on how to respond to a pandemic of several million people.
You know, you hear some people saying that that's what you trained for. Like, actually, this isn't what anyone really ever expected.
Their messaging to us was this is probably going to be your once-in-a-career situation.
Felt like you were preparing for war whilst providing a service for the patients that were in front of us.
When we heard of spread outside of China to other areas, that was really clear that our usual systems weren't going to cope with the evolving pandemic. We might need to take 200 or 300 patients in ICU. Looking at our peers and colleagues overseas, that was their reality.
Seeing what was happening overseas and, seeing all these healthcare workers getting sick, you definitely think like, oh, is that going to be me?
We got to the problem of trying to create space in places we didn't have.
We learned a lot about the virus very quickly in preparation because we were very worried about what we would have to do, what novel therapies we would need, where do we get drug X, does hospital have drug Y, all these kind of things behind the scenes.
We've changed the whole way our emergency department runs. We had a external triage area built to, make sure that the public wasn't anxious about coming into hospital and being exposed to COVID.
We've had to increase the numbers of hours that the lab operates. We've rostered extra people across weekends and overnights.
Adapting to what new policies and procedures will be put in on that morning, and the next day would probably change.
So I'm a clinic nurse. To then step up and get into the call centre and do assessments over the phone, it's tricky.
We were nominated by the Austin Hospital to become the COVID positive ward. When we first started, I was thinking, God, I don't know how I'm going to manage staying in this for 8.5 hours.
I was fearful of having to turn away people that needed good care. Department of Health, and they'd show you these graphs. And whenever the bar went like double the amount of what we could take, you're thinking, well, crap. So modelling really caused a lot of strain on us.
I had a massive panic attack. I got my dad to sort out the caravan in their backyard in case I had to, isolate.
We created a room that was our ED breakout area where you could just go and sit and cry.
I found it difficult to read books, watch TV, have conversations about anything other than coronavirus. We just felt the need to be so abreast of the science so that we could provide the best care, and we were writing the guidelines for how we would treat patients, that there was just no minute of the day that wasn't devoted to coronavirus.
It does make you think, like, how far would you go for your job?
It feels like a military kind of operation, to be perfectly honest. A lot of it wasn't about medicine, it's about coordination.
And then the other thing was really the constraints in the supply chain, so things like equipment and reagents for testing people, PPE, medications, and so forth. We were very fortunate that we didn't have to go through a really large first wave to buy us time to be able to prepare if we did have that surge for the second wave. People one of the things that, I've been reflecting on, particularly the second wave, is really when I think about what infection control is about. We always want to do what is right for our staff. It's about communication and education. I think if we can get people doing the basics well, that really stands us in good stead. The challenge for us is really around managing our workforce and staff fatigue and things like that.
I feel very privileged to be in a safe place like Australia and in a very controlled way be making a meaningful contribution.
Austin's always been a really good team. I've worked here for 20 years and I certainly wouldn't be going anywhere else.
I don't think I would have envisaged so many units working collectively together.
These sorts of things often bring out the best in people. People either just step up to the mark and just do what they have to do, or the other option is just to sit and cry in the corner, which sometimes was was an option I was contemplating.
We're a great team. I'm very proud to work where I work.
There's a lot of uncertainty, and I think there's a few times a week that I'm called to bring out my crystal ball and say what's going to happen over the next few weeks.
I hope that this just fizzles out like previous viruses have, and I will go back to being a general medical nurse.
Thank you. In those two showcase videos have once again reminded us of the significant roles that nursing group have played in the fighting against COVID-19. Let's pay tribute to our nursing colleagues. And that's all for today's webinar. And I would like to thank our speakers, Director Michelle Ramsey and Dr. Gordon Gali, and our panel discussants, attendees, guests, and viewers. To evaluate today's event, please head on over to the website on the screen or scan the QR code on the screen. You would need to be signed in your email accounts to answer the form. The program aims to bring together nursing leaders from academic, hospitals, and communities who hold key positions to prepare them for the challenges and opportunities for nurses in the implementation of primary health care, universal health coverage, and the commitments towards the sustainable development goals. As we end, we would like to acknowledge our speakers for their contributions. Many thanks to our esteemed guests, Dr. Gordon Gali and Mrs. Michelle Ramsey, and to our select course participants who represented their countries throughout the course. Thanks to our attendees as well for the productive discussion. Thank you to our webinar participants as well and the social media viewers. As for our panelists, see you on December 7th for our synthesis meeting. And now we'll stop streaming. Thank you all. Bye-bye.
Thank you, everyone. To those
Thank
enrolled,
you.
to those enrolled in the course, please stay for a little bit for our brief instructions. For our drill, our weekly drill, let's take this time to thank Michelle. Dr. Galia has already left, I believe, but Michelle is still here. So everybody, if you can turn on your cameras, let's all thank Michelle. Michelle, thank you so much.
Thank you.
Lovely to see you all. Thanks, Michelle.
Thank you very much, Michelle, and we hope to speak again with you.
Lovely to see you, Sheila. Thank you.
Yeah, you too. Thank you.
Michelle, on the screen are the organizing committee with the Peking Union Medical College led by Professor Hua Ping. Prof. Hua Ping, say hi.
Hi,
We know each
Michelle.
other well.
We'll meet next time face by face.
And of course, you know already Dean Sheila of UP College of Nursing, and the rest who are here from 13 Western Pacific region countries, some of the 26 enrolled participants in the Global Health Nursing Leadership Program are here, and we all thank you. We'll be sharing a video of your presentation as well as the whole webinar on the course site that where they put it, where they participate in the discussion forums and have additional exchange. If you want to visit the course site, we'll also send it to you just for you to view or interact or whatnot. Thank you for sharing all the materials that you shared. We'll also forward them to the group, and hopefully we can also share in our social media pages, if that is okay.
Yeah, that's fine. I had meant to send more references, but I didn't get to it. So if I get a chance, I'll do a follow-up email. Thank you.
Thank you so much, Michelle.
Thank you so much.
Thank you.
Soon. Bye.
So for everyone else, we will see each other again on December 7. So we will share our link. So you have your assignment for this module is your policy brief, and you have your situational analysis for module 1. You have your leadership journey for module 2, and you have your policy and advocacy assignment for module 3. So we will see each other again on December 7 for our synthesis meeting. And then our last activity will be on December 14. That is our virtual graduation from this course. So we will send further announcements to all of you. Jules will send more emails to you. So thank you so much for participating actively in the discussion forum. Can we give a big round of applause to Julia for moderating this activity? Thank you so much. Julia. And
Great job, Julia.
Julia will be moderating our activity for our synchronous session next week. So congratulations, everyone. So
thank you, Julia.
If you have more questions, please just send them over and we'll synthesize them. So can we have one more class picture? Our tradition, we never end without a class picture. Jane, you still awake? Good evening, Jane.
Hi, everyone.
Hi, Jane. We're always worried that
Hi, Jane.
it's too late for Jane is. So, okay, everybody, I'll take the photo. 1, 2, 3. Okay, thumbs up. 1, 2, 3. Great. So everyone will see you December 7. Bye.
Thank you, Jennifer.
Thank you,
Jennifer. Thank you, Dean. Thank you.